Hello and welcome everyone to the Toronto General and Western Hospital Foundation's first ever virtual speaker series on movement disorders. We hope you're staying safe and well and taking care of each other during the COVID-19 global pandemic. I'm Christian Cote, host of the University Health Network podcast Behind the Breakthrough, and I'll be your moderator today. We want to we are very grateful to all of you to be able to join us during this challenging time of the pandemic, and which is why we're coming to you virtually to observe social distancing and do our part to flatten the curve. Before we get started, we want to give special credit to Mr. Fraser Barrow. This event is being made possible because of his remarkable generosity. He is a shining light for his continued support, so thank you, Mr. Barrow. Another bright spot these days is the dramatic change underway in patient care at UHN's Edmond J. Safra program in Parkinson's disease, the Morton and Gloria Shulman Movement Disorders Clinic, and its Multidisciplinary Care Clinic. On today's broadcast, to help us better understand these amazing innovations benefiting our patients, we're pleased to be joined by Dr. Tony Lang. Dr. Lang is director of the Edmond J. Safra program in Parkinson's disease. Excuse me, the Morton and Gloria Shulman Movement Disorders Clinic, and the Rossi Progressive Nuclear Palsy Center. Welcome, Dr. Lang.
Thanks very much, Christian.
And we're also grateful to have with us Dr. Sarah Lidstone, a neurologist and director of UHN's Integrative Movement Disorders Program, as well as a clinician investigator at the Krembil Research Institute. Welcome, Dr. Lidstone. I think your mic is muted, Sarah. Now, before we hear from our guests, we want to remind our audience that we're dedicating the final portion of today's broadcast to your questions. So, as you're watching the presentations by Dr. Lang and Dr. Lidstone, if a question comes to mind, please go to the Slido page. You should see the link at the bottom of your screen. Type in the event code, that's hashtag MDSS, and enter your question for the doctors. And please keep in mind, for privacy reasons, they won't be able to field anything of a personal medical nature. Okay, so Dr. Lang first, let's start with the big picture here and the Morton and Gloria Shulman Movement Disorders Clinic. Talk to us about the clinic, Dr. Lang, and the challenges you and the program have had to address since the COVID-19 pandemic was declared back in March of this year.
Well, hello, everyone. Welcome to the speaker series. Thanks, Christian. As you've all been very much aware, we've had a lot of challenges over the course of the last few months, as you'd imagine. My job right now is really mainly to serve as a warm-up act to my colleague, Sarah Lidstone, who's really the most important speaker this afternoon. But I was asked just to give you a quick update to inform you that our clinical research programs are now coming back on stream. So many of the research studies that we were involved in have been on hold, although we've been maintaining contact with patients in research studies virtually by telephone or by other kinds of virtual connections. And the clinical care program is also coming back very strongly. So as with all clinics across the world, we moved entirely to virtual care very quickly. And now we're in a combined model where we're starting to see patients back in the clinic and maintaining virtual care in many cases as well. And in fact, a lot of the care that we provide can be done virtually, although we like to see the patients in person. We like to have connections. One of the reasons all of these people on this slide do what they do is that they like human connection. They like to take care of patients. They like the interactions and feel very strongly about the care that they provide. And so I hope you feel the same in your connections with them. Each and every one of these individuals is still involved in both clinical and research programs. Dr. Lidstone is on your far right. Dr. Kovacs spoke to us recently at another one of these speaker series. He's on the far left. And I should say, one of the things that has me very excited is some of the work that we're doing with Dr. Kovacs on diagnosis. So we're going to be doing a very detailed biomarker study where we hope the diagnosis of Parkinson's disease particularly is going to be revolutionized. And with that, the diagnosis of other neurodegenerative disorders. So we're on the verge of some really important breakthroughs. Our surgical program, Dr. Munoz and Dr. Alfonso Fazano, the bald guy with the beard at the back there, they're very actively continuing to see patients over this time as well, and we're increasing the number of people coming into the clinic for their necessary surgical evaluations. Rather than go through any of the other details related to my colleagues, each of them have spoken to you at one time or other, and they're going to come around and do other assessments and visits with you over the course of the next many speaker series. I think I'll probably just conclude there. So we're working through COVID. The clinical and research programs are now coming back online. And I think that from now on, we're going to see a difference in the way we manage our patients with more virtual care. And I think Sarah's work is going to change that as well. And so, as I say, I'm the warm-up act. Welcome. Thanks for your support for the clinic. I'll pass it back to Christian now, who will introduce Sarah. Thanks.
Thank you, Dr. Lang. Before we turn to Dr. Lidstone, a quick reminder to everyone out there. As you're watching the presentation, if a question comes to mind, please go to the Slido page. The link is at the bottom of this live stream window. Type in the event code, that's hashtag MDSS, and send us your question. Again, for privacy protection, we won't be able to field anything of a personal medical nature. All right, let's bring in Dr. Sarah Lidstone, who is spearheading transformational change in the delivery of care to patients with chronic neurological conditions. Dr. Lidstone, talk to us about what's happening with the multidisciplinary care in the new integrated care clinic at UHN.
Thank you, Christian. It is such a pleasure to be asked to do the inaugural virtual speaker series. The other ones I've attended have been really, really great. And so I really appreciate this opportunity to share about our work, what we're working on. We've been super, super busy, as you will see, but I hope this presentation is thought-provoking, gets you to think a little bit outside the box about how we can actually transform how we deliver the care of chronic neurological diseases. So Parkinson's disease, as many of you know, is a neurodegenerative disease that causes the loss of dopamine-producing cells in the brain. And the pathological hallmark is the accumulation of alpha-synuclein, which is a protein that we normally have that then just starts to misfold for reasons that we're studying in great detail. And what's really important, and what the focus of this presentation will be on, is I want you all to fully understand and realize that although it's classified as a movement disorder, it actually affects multiple different body systems. And so it affects movement, as I mentioned, but also thinking and memory and cognition, emotion, our autonomic system, including our bladder, bowel control, our blood pressure control, sleep, our skin, many different systems are involved. And so it's actually these, what we call non-motor symptoms, that are most impactful when it comes to patient quality of life. And this has been demonstrated now in multiple different studies and surveys of patients. And so there is this kind of divide between these motor symptoms here and non-motor symptoms down here. And we think actually the non-motor symptoms probably predate the actual onset of motor symptoms, which is typically when patients are diagnosed. And so the earlier that we can pick up some of these other symptoms is really important for trials for neuroprotective agents, for example. But what I want you to realize is that these symptoms will progress throughout the entire course of the disease. And so always we're having this balance of motor and non-motor symptoms that require a full multidisciplinary team to treat well and treat properly. So now, worldwide, neurological disorders are the leading cause of disability. And the fastest growing of all of those is Parkinson's disease. It actually has surpassed that of Alzheimer's disease. And globally, the numbers of patients who have Parkinson's disease will double from 6.9 million to 14.2 million by 2040. So this is coming. And already we're struggling to actually deliver good care to these patients, because in studies that have been done in the US and in Europe, 40% of these patients have never even seen a neurologist. And this is not even to mention patients in developing countries who often are never actually even diagnosed and have no access to dopamine replacement medications. We can treat Parkinson's, and these patients aren't even being diagnosed or even treated. And so there really already is a big, many big gaps in the care. In Canada, in terms of our population, by 2031, so 20 years from 2011 when the study was actually done, the proportion of Canadians who are age 65 and older is going to go from 15% to almost a quarter of our population. And this is going to bring with it increases in all of the conditions that are associated with aging, and the disability that's associated with those conditions, and the need for medical care, both formal and informal, as well. And so again, the need is exponentially growing. This has actually prompted the term the Parkinson pandemic. And I do realize the word choice may not be super appropriate given the current other pandemic that we're all facing, but nevertheless, this term has been published in JAMA and has been used. And this is showing that exponential growth I was talking about in terms of cases of Parkinson's increasing over time. This increased number of cases is also substantially related to the economical burden associated with these conditions. And so healthcare costs are increasing. It's going to actually double over the next 20 years from 2011. And Parkinson's has the third highest level of direct healthcare costs of all neurological disease in Canada already, actually. And as a group, Canadians who have neurological disorders do already use more healthcare services and other chronic diseases such as cardiac diseases or renal diseases or so forth. And so it is costing our system money. And Parkinson patients, despite us being in a fantastic universal healthcare system, actually pay the highest cost of prescription medications in Canada of all neurological disease. So bring you back to this kind of concept of requiring a team approach, because there are all of these symptoms, movement, non-movement related, that requires a full team of multiple different healthcare providers, both physicians and importantly, allied health, so physiotherapists, occupational therapists, speech language pathologists, sex therapists, dietitians. These are all really, really important individuals that can come together in some way to deliver care. And importantly, the work that we are doing in Parkinson's actually extends beyond Parkinson's. So Parkinson's, because of the nature of the symptoms being so variable across the entire body, can actually serve as a prototype, if you will, for all neurological disease in the country. Because if you actually take patients across all neurological diseases, they have the same concern. Their disability is actually related to cognition, mobility, and pain. And so if we get really good and nimble at treating this in Parkinson's, what we learn in Parkinson's can then be scaled up and applied to all other neurological conditions. And this is what the data in our own country is actually showing us. So with that in mind, our vision is to become pioneers and world leaders in delivering the integrated care of movement disorders. And what we do really well is we combine neurology, psychiatry or mental health, and physiotherapy or physical health in a holistic way to treat disorders of the nervous system. And so our goal is to build a whole new model of care. And so we've, as a team, come up with these list of 6 tenets that we are fundamentally using to grow out this model. So the first, and I'm going to go through each of these in detail in this in succession in this presentation. The first is that the model has to be patient or problem-based and disease-informed rather than being disease-based. The model has to be integrated both at the person level, so within the individual, but also at the system level. We really have to focus on emphasizing self-management and giving patients education and tools and skills so they can manage their condition, and with us supporting them as a team. The model has to be co-designed with patients and their care partners because we have to get it right. We have to know that we are addressing the needs that are not met currently in our patients. We want to have the model that embedded within a community network that is larger of trained healthcare providers, so links with the community, and also that takes advantage and incorporates and utilizes and leverages technology. So we are aligned completely with UHN's strategic plan in doing this actually, which was actually coincidental, and I'm very pleased about that. But UHN has declared that we want to lead the integration of physical and mental health to establish new standards of care. So we are bang on with the mission of our entire institution, which is great. And we are executing this with a new collaboration with Toronto Rehab Institute. So many of you already are familiar with our movement disorders clinic, and I won't go into that in a lot of detail, but TRI may not be as familiar to some of you. So TRI is actually the #1 leader in rehab research in the world. It's the largest academic adult rehab hospital in Canada, and they already have a lot of experience actually on the ground in clinical and research integration. So they totally know what they're doing, and they've provided the space for for us to be able to do this well and to support both intellectually as well as other ways. So I'm going to go through these 6 tenets of our model in a little bit more detail, and that's going to conclude the presentation. So first, let's talk a little bit about patient or problem-based care versus disease-based. So the old model is I see a patient and they have Parkinson's disease, and that is how I structure the visit and structure my history and what questions to ask, what examinations to do. But that obviously depends on which practitioner is seeing that patient. So as a neurologist, the neurologist might diagnose, oh, there's some tremor, there's gait dysfunction, maybe there's some mild cognitive impairment. And if they saw a psychiatrist might say, okay, there's some depression on board, maybe there's some anxiety or panic, there might be a history of trauma that's been unearthed in that interview that's quite relevant. A social worker, however, might say, well, actually, there's social isolation, the person is struggling at work, having a lot of challenges at home, and they're not well supported in their network. And then a physiotherapist here who's wearing glasses might say there's, okay, a fear of falling, and this patient has difficulty getting out of bed and standing up, or difficulty with getting dressed in the morning, for example, or can't compensate for different strategies. And so these are all different perspectives that are based on the scopes of practice of all these different healthcare providers. But the question is, what is the patient want? What are the patient's main concerns? What are the problems that patient is experiencing because of their symptoms that are affecting their quality of life and their ability to live a rich and fulfilling life? And is there a way that we can approach the problem differently by combining these different perspectives and reorganizing things so that we can actually treat the problems from a multidisciplinary approach rather than the other way around? So that is actually called a transdisciplinary approach to care. This is a table that I put together with Dr. Lang as well in a recent publication, just showing the different kinds of models of care that are out there with increasing levels of integration. And so most of you might be familiar with what we would term a monodisciplinary model, where a patient sees a physician, that physician then makes referrals to other doctors and they communicate via letters. But there's not much in the way of two-way communication. Some of these types of structures actually work quite well with great communication, and some work less well. So there's a massive amount of variability that exists on this spectrum of integrated care as you go from one end to the other. But what ends up happening, though, the more that you involve the patient in the process and the more that you bring the team together in real time, fundamentally what's actually required is a shifting in how you frame the problem. And so this is how you can then open up new creative ways of treating conditions, actually, that haven't been thought of before. And this approach is actually used in a lot of other industries, not just in medicine. So it's used in business a lot. And we can certainly borrow from these concepts and create something that's really novel and I think really compelling and really interesting. That's what we're doing. And so this is a patient who we treated in this type of model who has a different condition. It's called functional movement disorder, also a neuropsychiatric condition. So has elements of mobility, has elements of depression or anxiety, for example, as well as requiring physical therapy. And so she went through our program, and I just wanted to, we asked her at the end what she thought about how it went. And here's what she had to say.
I call you guys the 3-in-1 appointment because I don't have to spend the whole day or many, many months going to one doctor and then explaining it to another doctor and then another person. Mm-hmm. It's just, you guys are all together. I explain it once, and hearing me allows you to determine what to do for me. I don't know what to do for myself, but when you guys all come together, it's like, it's a more, I would say, better way of treatment. Because individually, it's like broken telephone. I think if everybody in the hospital did it this way, I think we would probably have less waiting times, shorter appointment schedules. Like, it all comes together, and I really think this affects this, and I need to do this to make all of this work.
So what she was saying is this affects her tremor and she needs to do physio at the end of that. So she's learned how to incorporate these different skills together. And so I think that really— I
call you guys.
So that's in terms of a problem-based approach to care. So now talking more about integration at the person level. And so what we know is that the most relevant factors, as I mentioned, for quality of life in Parkinson's are related to the non-motor symptoms. And there's a third of patients have depression at some point in their illness, at least a third of patients also have anxiety, which is twice the normal population level. And motor symptoms actually are strongly influenced by these psychiatric symptoms as well. So if a patient is depressed, they're already a little bit slowed down because they're Parkinson's, but they're even slower when their mood is low. If they're anxious and they have a tremor, their tremor is much, much, much worse when they're anxious. And so this actually opens up other targets for treatment. And patients themselves, if you ask them, will rate that the greatest unmet needs in care are exercise, mental health, and education about their disease. And so this is how we're going to focus the program. So the way that we're going to target that is we're actually building overlapping skills into the model. And so an example of this is we decided to hire Keshi, who's actually a mental health nurse, and teach her Parkinson's. So she's not a Parkinson's nurse. There are excellent Parkinson's nurses out there. We have a few in the clinic who are fantastic, but they don't have the mental health skill set, but Keshi does. So she can learn the necessary elements about Parkinson's, but then really use her skills in terms of anxiety reduction techniques or coping strategies or grief counseling to help patients even more. And then I pair her with Hasil, who's our physiotherapist. And now Hasil, in his physio sessions, is actually using relaxation techniques as part of his physio. So if we can build into the model these overlapping skills by having the team work together and train together, they then go away and actually transforms their practices too. And so the model then becomes a lot more efficient and lands on the same common things all of the time. And then we can standardize and operationalize those approaches. So the next thing I want to briefly mention is the importance of self-management. So what we've been working a lot on, especially since COVID, coinciding with the hire of a full-time education and communications individual who's Julie Rasiopa, we're building out a library of basically disease education, but also treatment skills. And all of it carries the brand of what we're doing, but we can actually share these resources with patients virtually and in paper and in person to teach them how to use these skills as well. So the skills building, I think, is really important, because when I speak to patients about this, many of them say, we just want to know things that we can work on now. What can we do now to help our symptoms besides taking medication? And so one example of this is this is actually literally just from last week. This is quite fresh. We're still in a brainstorm process, but this illustrates how we work a little bit. So for example, take anxiety. So if I wanted to teach a patient about anxiety, I think what we'd like to do is target how they can use these skills in their daily life, teach them what those skills are, but start from the bottom, which is knowledge about why this is important, right? So we can do this kind of pyramid type approach where we provide the knowledge first, we teach the skills, and then we teach patients how to apply those skills in daily life. And this can also be done in physical therapy. So for example, falls recovery. Teach patients the knowledge about falls, why this is important, what are the skills the body needs to be able to do to be able to recover from a fall, and then how is this important and how can you actually implement this in your life? And I think what's really cool about this approach is that you can actually combine these skills across different symptoms. So for example, with falls, a lot of falls is related to fear of falling. But if the patient has learned the skills about anxiety self-management, they've learned how to recover from a fall, this will substantially reduce the fear of falling. It will provide empowerment. It will make the patient more confident. And then all of a sudden, we've improved this by working on the physical stuff and the anxiety stuff together. So I think the sky's the limit with this approach, and I think it's a really cool way of delivering care that hasn't really been done before, certainly in movement disorders. So I'm almost done. Want to mention how we're going to co-design this program with our patients and their care partners. So we established a patient advisory board in October 2019. This is something I was very fortunate, kind of the timing is right, where as a clinic, it was already established that this was going to be something we wanted to pursue. And we just basically accelerated the process. But I realized very early on that we need to have the patient voice incorporated in how we're designing and building out this model. And so we need to have some type of board that we can interact with to ask them these questions and get their help. And so we are so proud of this board. We have 14 board members who are accomplished individuals, patients, and care partners as well, who are every step of the way helping us as we go through this process and navigating this. And the work with them has I can absolutely say been some of the most rewarding probably in my career. And it's a relationship that I love and that I actually treasure. And I just love working with these very energetic, accomplished people who I've learned so much from. So here's a token Zoom picture of one of our recent meetings. I just told the board chair, Hugh Johnson, that I would like to have a different picture where everyone's prepared for next time. But this board is really kind of knocking the socks off everybody, and they're killing it. So we're really, really proud of the work that they're doing. One example of this is we have a subgroup who's looking at research. And so they actually came into our clinic and looked at the entire way that we recruit patients for research and realized that we can make some efficiency improvements. And so we're working on implementing all of those to involve and engage patients more in research. So as I mentioned, Toronto Western Hospital, although we often think that we're the center of the world, we're not the center of the world. We have only a population of about 6,500 patients seen in the last 2 years. Most of our patients come from the GTA and Southern Ontario, but our patients do come from all over the province. And so the goal is actually to create a hub and spoke model where we occupy a center of expertise type of role. And we have community partners. So these can be neurologists who we empower to see more Parkinson patients, give them the resources so patients can be seen in their own communities. And the same framework can apply for physiotherapy, for occupational therapy. I was very fortunate to go to the Netherlands last year and saw their Parkinson Net model of how they do network-based healthcare over the entire country for Parkinson's, and it inspired me. And so we're going to be implementing something very similar here in Ontario. So this is just a map of where our patients live, and just to show you guys, they come from all over the country. And so finally, just as the last slide, where we are going to be, our intention is to be, regardless of COVID, an early adopter of virtual care. Virtual care, we love, obviously, as Tony said, seeing our patients in person, but from a rehab perspective, actually, there are benefits of being able to be brought into the patient's home and see how they can implement the skills that we teach them in their home environment. So is that transferability? We can actually see it in real time. So this here on the right just shows what our virtual appointments look like, where we have our patient, the psychiatrist, the physiotherapist, and myself. And then this is, I just want to show you a quick video of a virtual physiotherapy session with Hasil, who's very bossy and been brought into our patient's kitchen. So you can see this.
So I'm going to go from my wheelchair.
Yeah.
Get set.
Mm-hmm.
Get my arms on my chair and stand up.
Well, I want you to push off your chair, though. Your wheelchair first, though, right?
Yeah, push the wheelchair first, yeah.
Yeah. So I want you to stand from your wheelchair, and then what are you going to do after?
Get out of the chair.
Yep. And then what are you going to do with your head?
Look straight up.
Okay. And what's the task that you're looking to complete?
Open the cupboard door and grab a glass.
Okay. Let's do a few weight shifts before you do that.
Yeah.
Good. And whenever you are ready, you go ahead and do it. Good. You're gonna play slowly control with control now. Okay, a few inches, and you're gonna grab a seat, nice and slow. Beautiful. Wonderful.
You did a great job. So just to note, Hasil's actually never met this patient in real life. All the work has been done virtually, and this man was not able to get out of a wheelchair or stand before. So this has all been done virtual through using virtual therapy. So my final slide, I'll just tell you about what we're working on for this year. So last year was really about actually building and training our team, because we never had a physio in the clinic until just last year. And so we've done a lot of work with hiring a great team and training them and starting to lay out the groundwork for this year. So this year, really, we're gutting it out, piloting 3 different clinics. So we're piloting a assessment clinic for Parkinson's using that integrated approach. We've done it already in another movement disorder called functional movement disorders, and we had great success and published that work. Now we're trying to apply this, what we've learned, into the Parkinson's disease population. And we're actually building this out with patients. So we're doing focus groups with patients, trying to kind of workshop test visits, and we're improving things as we go and collecting data on it as we go using a quality improvement kind of framework. We've also now piloted a rapid access mental health nurse-led clinic. So Keshi's seeing patients within 2 or 3 weeks who have concerns about mental health. So we can get at patients early and help them early so they don't have to wait 8 months to see a neuropsychiatrist. And we're also piloting a drop-in model. So the idea is once we teach patients the skills, then we may not have to see them at these regular 6-month follow-ups, but instead they can come to us for topping up of the skills they've learned, and we can help them out that way. So that also confers self-management and autonomy with patients as well. As I mentioned earlier, we're building our virtual library of all the existing resources online for all these conditions. It's a huge amount of work, but we don't want to reinvent the wheel if we don't have to. So it's about seeing everything that's already out there, organizing it, and then filling in the gaps, and then figuring out a communication strategy to then share it with our stakeholders. And now, and very importantly, this year, we're also developing the beginnings of our research program, because none of this means anything if we can't demonstrate that it works and show that it saves money, and then get grants to actually continue the work and scale up. So that's the goal of this year as well. So that's it for me. I just wanted to end by acknowledging this work is 100% kind of team-based. I couldn't not do this alone. First and foremost, this work has been funded by anonymous donation for the neuromodulation multidisciplinary care, and without that donation, none of this work would happen. And so that has led us to be able to actually hire a team. So it's been crucial. The Patient Advisory Board, as I mentioned, for always providing excellent advice and support. And just, I didn't mention this, but I do have a little secret business advisory board of Toronto business leaders who've all been touched by Parkinson's, who are helping me with strategy, with financial planning, with communications, all these kind of entrepreneurial things that I need to know to grow a program and do it well and make sure it's sustainable. And I have to mention these people. This is our Integrated Movement Disorders program. This is our team, who are outstanding, talented, creative, dynamic, hardworking individuals who do not conform to a 9-to-5. They work in the evenings, they work on the weekends. We are literally operating like a startup, and they're doing incredible work. Toronto Rehab, Dr. Mark Bailey, who is the medical director, has been unfailingly supportive. And then also, obviously, Dr. Lang and my parent clinic, the MDC, for all the support they've given me through this time. So thank you very much. I'll take any questions.
That's amazing insights. Thank you so much, Dr. Lidstone, for helping to us better understand this integrated model of care, which seems like one-stop shopping for us lay people, and for the outlook of the program in terms of the future, in terms of care, and also in terms of research. That's terrific. Okay, as you foreshadowed, we do want to get to your audience questions that have been coming in on Slido, and we're going to pop up the Slido graphic there. And we have not rehearsed this, so I'm going to bring up the question, and I'm going to sort of let the two of you figure out who should field this. The first question that's come in is, can you talk about the length of such a care and treatment model for patients with movement disorders? Who wants to tackle that one?
I can probably best tackle that one, Tony, if that's okay with you. I think the first answer is we're not sure. We're figuring it out as we go a little bit. What the research shows in terms of rehab for Parkinson's specifically is that the timing in terms of when the rehab is delivered throughout the course of the disease does matter. So patients who are in their earlier stages and who are have more of a physical capacity for exercise, for example, tend to respond more. But studies that are also done in later stage Parkinson patients do show that if they do receive intensive therapy, they can actually show substantial gains as well. So we have to play around with this a little bit. What we're thinking, because we have to treat so many patients, we're not in a position where we can provide a standard carousel type of model of care where the patient is seeing each specialist separately and then getting suggestions. The idea is to teach tools, teach education, teach self-management, and then have top-up care delivered at regular intervals. So likely that would be shifting throughout the entire course of the illness, but we're still working on the duration of how that's actually going to look.
Terrific. All right, another anonymous question. Is there physiotherapy specifically for movement disorders? And if so, where? And is it covered by the government?
So I can answer that one as well. So there is physiotherapy for movement disorders, but it's absolutely not kind of protocolized unless it's related more to stroke physiotherapy. So a neurophysio who might treat stroke where there could be problems with walking, for example. So the first thing I would say is that neurophysios could treat some aspects of movement disorders as part of their scope of practice, but in terms of actual evidence-based methodology around physio for movement disorders that doesn't exist yet. There's many different studies that look at many different types of physio. So some have looked at boxing as physio, some have looked at Tai Chi, some have looked at just exercise programs specifically increasing cardiovascular output. So I guess the jury and the evidence is still out. In terms of covered by the government, right now there's only a handful of OHIP funded clinics in Ontario. You can actually Google OHIP covered physiotherapy and look at a list of clinics. Those clinics have a certain amount of money they're allotted to by the government every year for OHIP covered physio. And so it's up to them to decide how to actually use it. So in general, right now, the bulk is still delivered by private funding.
All right. And sorry, Dr. Lidstone, did you say where this is at? Is this at Toronto Western and Toronto Rehab or one of the two?
So still in the community. So right now, it's still you're really lucky if you can find a therapist who's interested in treating Parkinson's. Our physio that we hired actually came from the community. He already has a network of physios. So we're looking to solidify that network and then give that information to patients. So that part of things is coming. Doesn't exist yet, but it's in the pipeline for the next couple of years.
Got it. Okay. Next question, also anonymous. Where at UHN will this program be offered? I guess you were basically starting to explain that.
Yeah, so for now, it'll be offered mostly at Toronto Rehab and virtually. We would like to be able to incorporate some of this work in terms of especially the mental health side at Toronto Western in our movement disorders clinic there. Ideally, though, eventually this is going to be delivered in patients in their own communities. So the idea is to decentralize this care into the community as well, but we're still like 4 or 5 years away from that.
All right, next question. How many patients per week will you be able to treat in this program?
So the goal is we're going to have to meet the need of our clinic, which, as I mentioned, our last analysis showed we have about 6,600 patients in the clinic to treat. So we can't do that now. We're still in the pilot phases now. And we recognize that we'll never be able to offer that to everyone within that clinic itself. Our plan, as I mentioned, is to scale up the model and spread it to other areas. So our goal is to reach every single patient with Parkinson's with this treatment. It may not physically be at Toronto Western, but it may not have to be. So this means then that a patient who's followed by a different neurologist in the community would ideally have access to the same type of therapies that we're talking about. And
there is the component which you showed in the second video, the potential for also a virtual care and virtual follow-up, which could also supplement not having to come into the hospital.
Yeah, absolutely.
Next question. How can I support the program? And what would you say is the most urgent need for support?
Yeah, that's a great question. I mean, we need a few things. Certainly, our next hire is going to be a social worker to be delivering some types of psychotherapy. There is a massive need for that in the program, as well as occupational therapists, speech language pathologists. So personnel needs are still high in terms of building the team, but also technology that enables us to actually build out a network. This is really important because how do we maintain a network? How do we create the network? How do we maintain certification within this network? So that's going to certainly take resources as we scale up as well. I don't know, Tony, if you had any other based on our conversation.
You get a free plug here. You might as well tell people where you need money to go.
Well, I think I'd reiterate what Sarah's already said, that this program would never have come up online if it weren't for the generous support of one particular family. And we hope that in the very long term, we will be able to convince government and other funders that the performance of the program and the outcomes of patients going through the program will be such that they have no choice but to fund, because the patients going through the program will do better, they will require less care, they will have less funding or resource needs, be able to stay working, and a variety of other things that hopefully will pay back to the system, the healthcare system. But that's going to take a while, and that may be wishful thinking, although I think any of you now that have listened to Dr. Lidstone hear the enthusiasm and the incredible job she's done will certainly believe, like I do, that this program has legs and will continue to thrive and will succeed. I think if there are people listening that want to support, what we'd really appreciate is if you donate to the program and then allow Sarah, myself, and the team to decide what the priorities are. And I think the priority she's given you, social worker, involvement in more technology, the building out the hub and spokes kind of model that you saw and advancing that are really the prime priorities currently.
Fantastic. From a next question, guys, from a health equity perspective, what about clients that cannot use or afford the technology needed for virtual care? This has become an increased concern and barrier to care during COVID. Good question. Who wants to handle it?
I can speak to that for sure. So this is a concern of mine, absolutely, and something that I've also brought up with our patient advisory board as well as is the issue of equity. It's actually not unique to us. So I sit on a citywide virtual care quality improvement at the University of Toronto. We have a working group actually across all the hospitals, and this issue is now coming up again and again. We've actually dedicated a separate working group just to this topic because we're all recognizing that if a person does not have access to a webcam or a microphone, they are not receiving as good care. And so that brings up a really important fundamental case around equity, which is at odds with how our healthcare system is the spirit of our entire universal healthcare system. So it's something that is a real problem that I would say is going to take thought and time to sort out, but it is happening on a citywide and certainly provincial-wide level, I think. But absolutely, it's a concern, and we're very aware of it.
It's a tough challenge, right?
Yeah.
Here is what directed to you directly, Dr. Lidstone. How do you determine which patients qualify for the IMDP? And is there a wait list?
So I know, so it's going to be a great program, but right now it's still in the pilot phases. So we're still actually figuring out what is the model and how does it work best. And so this is the funding that we've received, I probably wasn't very clear, is for 5 years. And we've now ended the first year of the program is done. We're starting our second year. So the goal is to, by the end of the 5th year, have the model seamlessly integrated kind of back into the movement disorders clinic, right? So we're kind of a little protected offshoot operating in Toronto Rehab right now as we figure out how to do this well. And once we figured out how to do it, it's then about proving that it works and then integrating that back into the regular patient flow of the movement disorders clinic. So right now it's basically done on a pilot basis. We are seeing patients referred by Dr. Lang, by my other colleagues, essentially who have any movement disorder, who have a requirement for some mental health support as well as physical therapy support. So it's pretty loose criteria right now because we're still learning. There isn't a wait list because we're only setting a cap with the number of patients as we learn this model. So hopefully, maybe in a couple of years when I do a speaker series again, I'll be able to give okay, here's the criteria, and you'll come on, have access to the program, or go down the street and see, your neurologist there. They can have access to the program, but we're just not there yet. We're working on it.
Fair enough. Next question from Anonymous. How often do patients have these virtual consultations with Dr. Lidstone's team?
Yeah, so right now we are seeing only, as I mentioned, because we're in the pilot stage, is a handful of patients a week. What the goal idea, what we'd like to move towards is a single assessment appointment where the patient first actually meets with a nurse and goes through an intake where we learn all about them. And we draw from that, what are the priorities for that patient that they need help with right now? And then the visit is done in that integrated format that I mentioned, because then we're not spending the bulk of that visit gathering data that we can just siphon off into a form, and it allows us the freedom and the time to really get to know the patient and their family and understand what their concerns are and start to problem solve what treatments could be helpful. The idea then is to plug that patient into a stream of treatment. So they'd be allocated to perhaps a physiotherapy-based stream, perhaps a more cognitive behavioral therapy-based stream, or a combination of both, or different types. It would be perhaps a speech language stream, and then teach them skills along the way, and then have a follow-up appointment. And the idea is then to use those skills down the road, and then have that patient then seen as a drop-in basis afterwards. So that's the model we're working towards now. But again, this is in evolution.
Next question is from Hugh Johnston, who asks about hashtag MDSS. Money question here. Assuming the research needs to be medical system funding model agnostic, will it make more economic sense in a patient lifetime in Canada versus Denmark versus the USA? His question is, do you have any thoughts on government or insurance funding of an integrated model, and will decrease costs?
Yeah, so that's my hope, right? So if we, the less disease specific we make the model, the greater applicability it has across the whole system. And so the key things are determining outcomes that are of relevance to the ministry and the government. And so it's about engaging the ministry early and say, okay, what do you want me to show you in 3 years that will have you fund this program? So build those outcomes into what we're looking at. We have partnered with a health economist for this purpose to actually help guide us along which are the outcomes we should be collecting, because I do fundamentally think it's a cheaper way of delivering care. But also, we do have a member on our business advisory board who is well positioned in the ministry. He's got a lot of experience in that area, so he's also providing advice around that too. So it's an excellent question, Hugh. And those are my preliminary thoughts. I'm not sure, Dr. Lang, if you have anything you wanted to pipe in about there. I don't know.
No, nothing to add there.
Well, Hugh skipped down. Sorry. Next question. You mentioned pain as a symptom, but you didn't mention pain control as part of the integrated program. How do you treat pain, please?
Yeah, so it's a really big question, and a lot of our patients suffer from chronic pain. And so chronic pain is treated by a huge, vast array of different, mostly non-pharmacologic strategies. And there's already a massive amount of work and literature that's done in this area. There's a really good pain program at Toronto Rehab, so we're starting collaborations with them to try to kind of bring them in as a collaborator to actually help potentially do a separate treatment stream. I obviously can't provide specific medical advice over this format, but it's a complex issue. It needs often a very thorough evaluation, detailed understanding of triggers, of psychosocial factors as well, and any underlying other factors that could be making pain worse. So it's a big question.
Hugh Johnson is back. Can you describe how you're going to test and adapt your model to what you learn from each pilot group to get a better model that is more robust and sustainable?
Yeah, so we're adopting, so just to kind of point out that typically in science and in medical science and research, we do a randomized controlled trial, which is the gold standard way of how we would demonstrate efficacy beyond some kind of control condition. But that only works when you have a very clear and specific intervention, for example, a medication. So after everything that I've described to you, this is a far more complex intervention. So it's actually not well suited to be tested in that kind of format. What's actually much better is to use a quality improvement framework, which is based upon this, what's called a PDSA cycle, which is used a lot in business and actually was invented in the Japanese auto industry in the 50s. And the idea is that you take a small number of patients and you test something out, you figure out what worked, what didn't work, and you make a change and then test it again. And so you do this series of iterative improvements that are very well thought out, that have very clear metrics associated with them about how to measure what worked and what didn't work. So it's still based on data. And then you use that as a way to land on a model that seems to work. And then you test it in a research study with many, many more people, with randomization, and then you can actually demonstrate efficacy that way. So we're planning to use this mixed methods approach.
Terrific. So potentially then there's lots of iterative in the process for the next 4 years that could be modified over time depending on where evidence takes you. Yeah,
because we're learning as we go, and we're learning with our patients as our partners. And so who am I to come in and say, okay, this is how we're going to do it? It's fundamentally 180 degrees of what we're trying to do here. Mm-hmm.
From Francisco, other than genetics, what are the most common triggers of PD?
I feel like Dr. Lang hasn't been able to say anything.
I'm enjoying listening to you, actually. So simplest answer is we don't know the cause of Parkinson's disease in the vast majority of patients. There are some where genetics play a very, very important role. That is uncommon. Maybe 5% of patients, certain populations have higher incidence of genetic causes. But we think of this disease combining genetic predisposition with certain environmental factors, and the how in which this combination occurs to result in Parkinson's really isn't known at all, and remains a very important issue that requires a lot more research. I think just to finish responding, it's worth emphasizing that to think of Parkinson's disease as a single disorder is really incorrect now, and we believe that this is many disorders. And the simple experience with genetics tells us that. If several genes are capable of causing a disorder that we think is all the same, it clearly tells us it's not, that many genes can cause independently the development of this disorder. So it's a very complicated situation. All the more reason that we need to concentrate on many therapeutic approaches. And this multidisciplinary approach is really very critical, because we're a long ways away from solving the problem and preventing it from happening. So we need to develop therapies that manage our patients today.
Thank you. Next question. Have you evaluated 40 hertz light / sound treatment for gamma waves for PD? I've never heard of that.
Neither have I. I personally have not. I'm not sure, Tony, if you had any experience.
Light therapy, as is used for depression, particularly seasonal depression, has been shown to be effective in Parkinson's disease. Probably helps sleep as well as mood, and there is some evidence that it may even help some of the motor features. So there are companies that are developing specific light therapies for Parkinson's. I'll be honest with you, I don't know this sound and gamma waves side of things though, so I apologize.
Everyone's going to be quickly going to Dr. Google, I'm sure, right after this.
Probably.
Yes.
From Mark D, are you looking at assistive devices that help with typing when tremors are present, or a voice activation device that assists when lower voice projection?
Yeah, like these technologies are being explored elsewhere. We're not in-house developing any of these presently. I'm always interested in incorporating technology. There already are some things that are out there for dystonia and writing, for example, for writer's cramp. The tremor glove is being used as well, but I'm very interested in partnering with people who are doing this work, but we're not doing this work ourselves specifically.
This is a great question. The next one, are you still looking for people to join the patient advisory board? Is there a way for people to get involved?
Yeah, that's wonderful. We have to talk to our chair, but I think we're always looking for motivated, dedicated individuals for sure. We've just been in operation we're coming on our 1-year anniversary. So we're in the midst of doing a exercise to kind of look back and say, okay, what worked, what doesn't work, how can we go forward, what are our priorities? And so this is a great time to ask. So I would say if anybody is interested, they can contact us for sure.
Fantastic. And forgive me for not pronouncing this properly in advance, from Shariar. Is there any link between foods, especially grain and dairy foods, with PD?
So
not really.
Yeah.
I think there has been maybe one paper discussing the role of dairy foods with Parkinson's, but as with many epidemiological studies, this requires huge numbers of patients to be able to show even mild or questionable associations. So I don't think there's any evidence of that. There is a lot of interest in things like the Mediterranean diet, however. Whether this is really an impact on Parkinson's or other brain factors, such as strokes and other things that we know can be prevented by Mediterranean and good diet, is not clear at this point.
Dr. Lidstone, did you have anything to say?
No, that's perfect.
Okay. Next question. With gradual but clear loss of balance, how can doctors correctly assess whether age-related or arthritis in joints or, in fact, Parkinson's progress?
Yeah, so this is basically the job of a neurologist. There's many different things that contribute to poor balance, including all the things that were listed here in this question. And so Parkinson's will have specific signs and symptoms that are associated with it. We can usually tell on a detailed examination kind of what is contributing with what, but it's a very good point. As we do get older, often it's not just one thing. It's seldom only just the Parkinson's if there is arthritis and pain and weakness on board as well. And so that's our job. We have to assess those things.
Next question from Eleanor. Can healthcare specialists distinguish from the first diagnosis what kind of prognosis a patient will experience? What factors are involved in achieving an upbeat personality? I'm not sure about the connection there, but
I like the question though, and I'm not sure how to answer that. But I can say we are cautious around prognostication. Generally, I can say what I tell my patients is Parkinson's will tend to progress at the rate that it's been progressing. So it tends to be a kind of a straight line, and that line is different in different individuals. And so that's generally what I tell my patients. I'm not sure, Tony, if you had other thoughts on that.
Yes, there have been many attempts at subdividing patients into different subtypes, some of which may have a more rapid progression than others. Predicting, however, in an individual patient, particularly when we first see them, it can be very difficult. And so, as Sarah's indicated, your past experience is often your best measure of what to expect. There are some factors that may help predict, but they're not completely reliable. And in terms of an upbeat personality, I think obviously with that, you do better with whatever disease you have. I'm not sure how we can get people to achieve that. Maybe by interacting more with people like Sarah Lidstone.
Well, I was going to say the one-stop shopping, I'm sure, might help a lot to boost upbeat personality, given you're getting all the medical care and medical treatment at one time rather than at different appointments. Mm-hmm. From Renee L. Is Dr. Lang's team will be working on the new University of San Diego breakthrough discovery announced in June on possible cure for Parkinson?
Well, I'll be honest with you, I don't know what that possible cure is. There are a lot of claims out there. There is nothing that is available now or in the immediate future that one could really consider a possible cure. And one of the reasons for this is probably something that I mentioned before. We're probably not dealing with a single disorder. And so it may be that certain subtypes may be curable, or at least their course may change or be changeable with specific interventions. And one of the best examples I can think of are the genetic forms. So there are, in fact, 2 genetic forms of Parkinson's for which specific treatments are being developed and studied now. And these look promising, but they're still at a very early stage. So there are a lot of claims, a lot of hopes for new research findings. And some new research findings are coming along very rapidly and in very exciting fashion. But I don't think that the University of San Diego has made a sufficiently important breakthrough discovery that a cure is on the horizon.
Well, thank you for clearing that up then. This looks like probably our last question as we approach the top of the hour. Can you kindly comment about patients requesting assistance with the MAD program?
I think that may be referring to MAID rather than MAD.
Which is likely.
So MAID is medical assistance in dying. Right. And maybe it would be best to leave that in case that's not what they're getting at. Sarah, do you know what a MAD program might be?
No, I actually thought that it said MAID. I interpolated a letter that's not there. So I thought that it was MAID as well.
All right. Best to leave it at that then.
Just let me say that MAID, medical assistance in dying, is legal in Canada, is a very reasonable consideration in patients, some patients with neurological disorders. If you are interested or concerned or want to know more about that, speak to your doctor. All doctors in Ontario or in Canada are obliged to refer patients to appropriate counseling and care that might lead them to choose that or might lead them to change their mind. It's a very complicated question.
Thanks, Dr. Lang. And I'm afraid we have come to the end of our time today. I want to thank both our guests, Dr. Tony Lang, Director of the Edmond J. Safra Program in Parkinson's disease, the Morton and Gloria Shulman Movement Disorders Clinic, and the Rossi Progressive Nuclear Palsy Center. Thank you for taking the time to be with us, Dr. Lang.
Thanks, Christian.
And Dr. Sarah Lidstone, neurologist, director of UHN's Integrated Movement Disorders Program and clinician investigator at the Krembil Research Institute. Thanks so much, Dr. Lidstone, for talking to us about your transdisciplinary care model.
Thanks, Christian. It's an absolute pleasure. Thank you.
And thank you to all of you out there for joining us. We will be returning with another edition of this movement disorder virtual speaker series in spring of 2021. This program is also being recorded, so if you want to watch again or tell your friends, you can direct them to the Toronto General and Western Hospital Foundation YouTube page. And as always, if in any way you are capable of interested in donating to the Movement Disorders Research Program, you'll find a link at the bottom of this streaming window that will direct you to our donation page. Your support is very much appreciated. Thanks for tuning in. Keep practicing physical distancing. Keep washing your hands, wear a mask, and stay safe, everyone.
Thank you, everyone. Bye.